Okay, good day, class. I had to do this video to prepare you for your practicals. I understand that throughout last week you guys had practicals and then you were shown a lot of lesions in preparation for your exam. So I thought it wise to do this recording since I taught you pathology of the cardiovascular system before I went on leave. So what I'm going to be showing you here is just going to be like a summary of the teachings, the lectures that we had during our session in the classes. And of course, I remember I gave you materials with a lot of pictures, and of course, some of those pictures is just what I'm going to be showing you here. So I advise that as you're looking through this video, so you're going through this video, just get your materials close by to help you understand and of course to prepare you for your practical exam and of course your viva. Now before we go in, it's important that I let you know that almost everything that we're going to be discussing, as a matter of fact, almost everything that I taught you from this book, Pathology Basis of Veterinary Diseases. I remember I urged you to get this book, and I'm still urging you, go download it. It's not something that you're going to use just for this particular course, but it's something that will help you should in case you decide to practice veterinary medicine. It's something that's going to help you in your vet practice. So get this material, James Zachary's 7th edition, that's what I use, but there are more recent editions now. Okay, so before we start talking about the pathology of the cardiovascular system, it's very important that we first of all look at the normal. Okay, let's look at the cardiovascular system. So basically from the name cardiovascular, it's talking about cardio, the heart, and then vascular, the vessels. Okay, and it also involves the lymphatics as well. But for the purpose of this practice, I'm going to be focusing basically on the heart and then of course the blood vessels. Now it's important that we do a review of this system and also to understand the hemodynamics, because once you understand how the blood flows, how the blood circulates to the system, then an understanding of the pathology that could arise should in case anything goes wrong in this system will be easy for you. Now the system primarily is made up of the heart, okay, the heart, and of course the heart has 4 chambers. It has the ventricles, both the left and the right ventricles, and also it has the atrium, the left and the right atrium. Okay, now it's also important that we establish again at this level that the right atrium and the right ventricle receives and conveys the deoxygenated blood to the lungs, and of course the left atrium and the left ventricle receives and conveys oxygenated blood throughout the body into the systemic circulation. So now look at if you look at the yellow ball, okay, I thought it was going to move. Okay, the animation is not coming on. Anyway, you just have to discuss it. Now, you see how the blood flows starting from, let's look at hemodynamics starting from the left ventricle. Now, when the heart pumps, blood leaves the left ventricle through the aorta, okay, and then moves into the systemic circulation where the oxygen gets used up in the system, okay, and then the deoxygenated blood then returns to the heart and it goes into the right atrium. Then from the right atrium it goes to the right ventricle through the right atrioventricular valves, okay, and then as the heart also pumps, beats, the blood gets pushed through the pulmonic valve, which is this, okay, and it goes into the lungs, and on getting to the lungs, the blood gets oxygenated, and then of course the oxygenated blood returns back to the heart through the pulmonary vein and into the left atrium, and from the left atrium down again to the left ventricle, and the cycle of course continues. Now this picture here also represents what happens in the circulation of the blood. Now it gives you a more detailed picture of what happens in the systemic circulation. Okay, so as the blood leaves the heart, it goes into the different systems. You can see here the digestive system, the liver, of course the intestines. Then of course here you also see the urinogenital system, the musculoskeletal system. Now these organs in this system uses up the oxygen in the blood, and of course sends back the deoxygenated blood through the venous system back into the heart, and of course the heart pumps it to the lungs. It gets oxygenated, and then the oxygenated blood from the lungs comes back into the heart to the left side, and of course the cycle then continues. Now this picture here also gives a more detailed explanation as well. You can see how the blood moves. Of course, you know that the blue here represents the oxygenated blood, and of course the red color, or let's say, I don't know what you're going to call this, but you say color is in the eye of the beholder. Okay, now it looks like I don't know, pink, whatever. Now this represents oxygenated blood. Okay, so you can see that as the blood comes into the lungs, it moves through the arteries, arterioles, then the capillaries. This is where you find the alveoli, the capillaries that surround the alveoli. That's where the oxygen and of course the gaseous exchange in general takes place. And then the blood also now returns, oxygenated blood now returns to the veins, back to the heart, and then of course the cycle continues. Now it's important that we also look at the heart. Okay, now if you look at the heart, you can see that the heart has a broad base and a pointed apex, right? And of course, like I established earlier, you have the left ventricle, the right ventricle, the right atrium, and of course also the left atrium. And you can see the pulmonary artery emanating from the right ventricle. Okay, this A here represents the aorta, and it connects with the left ventricle here. Now you can see this yellow dot. Now this line, this structure you are seeing here is where you have the coronary vessels. Okay, you can see it running from this area and runs towards the apex of the heart. Now it has a diagnostic significance at postmortem, because this aligns with where you have the interventricular septum. Now the interventricular septum is the mass of muscle that separates the left and the right ventricle. And at postmortem, if you want to examine the heart, you use this as a landmark, okay, and then cut open the left heart, taking about 1 to 2 cm to the left from this mark. Then you cut open. In that way, you cut open only into the left ventricular cavity. So you can now be able to examine the heart chamber. When you are done examining the heart chamber, you do the same thing for the right, and then you can see what's actually going on in there. Now, another thing I would like to establish again at this point is that you have to know that the left ventricle is about 3 times thicker than the right ventricle. So that's how you primarily know which part of the heart that you will be dealing with at postmortem. So when you hold the heart, you palpate it, you touch it, and when you feel it, you will notice that the thicker side is the left ventricle, while the more flabby side is the right ventricle. Okay, I think I've already said this. Now let's look at the other structure you find in the heart, which is the pericardium. The pericardium is also a very important structure, and I think it's important to establish also at this point that the pericardium has 2 major parts. He has the fibrous pericardium, and then he has the serous pericardium. Now, the fibrous pericardium is what you see on the outside when you cut open the thoracic cavity and you're looking at the heart. That structure you are seeing, you're not exactly seeing the heart muscles. You first of all have to see the pericardium. Is when you cut open the pericardium that you can now see the heart. Okay, so that part you are seeing is the fibrous pericardium. Now, on the inner side of the fibrous pericardium is where you find the serous pericardium. And the serous pericardium is what lines what we refer to as the pericardial cavity. Okay? Pericardial cavity. Now, I also want to state at this point that the pericardial cavity, if you remember I made this clear in your class, normally has some volume of fluid that is inside it. And this fluid serves as a lubrication. Okay, that allows the heart to beat freely. It's like a lubrication, it's like an oiling. Okay, just like you have in engines of vehicles and generators and all that. So it allows free movement of the heart as the heart beats within the cavity. Okay, now you have also this. Now the serous side of the pericardium is what makes up the cavity. Now, in this serous pericardium, it has two sides as well. It has the parietal layer, that's the one more on the outside, and then the visceral layer, the one on the inside. Now, the visceral layer is also the epicardium. Okay, please have that established. Now, this is another picture that's trying to show, to depict the entire wall, cross-section of the heart wall. Okay, starting from the outside, you can see the fibrous pericardium, then you can see the parietal serous pericardium, then the cavity or the pericardial space, then you now see the visceral layer, which is also the epicardium. Okay, then the myocardium, endocardium, then of course on this side is the inside of the heart, while this is the outside of the heart. Now, I'm sure that is quite clear. Now, having said that, let us now look at some basic pathology that you get to see in the cardiovascular system. The first one here is the chicken fat clot. Okay, the chicken fat clot. And I think you already know, as you already know, this chicken fat clot, it gets the name from the appearance. It looks like fat, right? It looks like fat, and of course it doesn't really have any particular shape. I don't want you to associate with this shape you are seeing and say this is how chicken fat clot looks like. No, that's not how it looks like. All right, now the chicken fat clot, just like a blood clot, takes the shape of any vessel that it is domiciled in, that is located in. Okay, and what is the importance of this chicken fat clot? First of all, it suggests that there was severe anemia before death. It suggests that the animal must have suffered from severe anemia before the animal died. Okay, that's the first thing. And also it also suggests that there is systemic inflammation or septicemia, because these conditions, that's inflammation or septicemia, usually associated with high erythrocyte sedimentation rates, right? Yeah, but however, it's quite common in horses, because horses under normal conditions have high ESRs. Okay, so when you see it in the horse, you don't necessarily have to associate with anemia or maybe septicemia or whatsoever. I hope that's clear. Now let's look at the second lesion. Here we have two hearts, okay, and obviously you know the one that is the normal heart. You can see here that this is the abnormal heart, and you can see it's now looking like a ball. It's now looking like a globe. Now this is what is referred to as cardiac dilation. You can see that the heart becomes dilated and becomes like a globe. We call it globose. So you can say that the heart becomes globosed. You can see it now has a rounded apex, okay, contrary to what you see in the normal heart that has a pointed apex, right? And another thing that you also notice in this condition when you palpate is that the muscle walls becomes flabby. Now this is what you find in a state of cardiac dilation. Now let's look at what happens at a cross section. Now you can see a globose heart here, a cardiac dilated heart. As cross section, you can see that the chambers, that this is the right chamber, this is the left chamber. You can see that the chambers are widened, and of course the muscles are now thinned out because it's now stretched beyond its limits. So it now looks thin, right? And this is a very terrible state. Any animal that gets to this state, even humans, will eventually end up with cardiac failure, because the muscle cannot function effectively when it's stretched out. It's just consider maybe like a catapult. If you have a catapult that the rubbers are still very fresh, when you pull it, the rubbers becomes more effective. But if the rubber now stretches out, okay, maybe catapult may not really augur well with most of you. Now think about the rubber band in your boxers or in your pants, right? When you buy it newly, it is very tight when you are wearing it. But after a while, if you are someone that's on the big side, you notice that it stretches out and it begins to slack. At some point, it can no longer hold, and it will cause your boxers or your pants to begin to, drop, and since it cannot function normally, of course, it becomes of no use. So that's what also happens in this condition. When the muscles are all stretched out, the cardiac function will fail, and that results to what we call cardiac failure. Now, on this other side, you have the opposite of cardiac dilation, which is cardiac hypertrophy. Now, you remember that earlier we've established that the right cardiac muscles, are thinner than the left. Remember, we said that the left is about 3 times thicker than the right. Now, if you look at this cross section, you will see that both the left and the right are almost the same thickness. Now, this tells you that there is cardiac hypertrophy. Okay, so this is what you see in the case of cardiac hypertrophy, right? So what it simply means is that the right heart had to do more work to be able to maintain the cardiac output, and due to that, the muscles had to hypertrophy to be able to push out and maintain the normal cardiac output. Okay, now this next picture here is showing a schematic drawing of what we just talked about. Now you can see the normal heart, and here you can see the hypertrophied right heart. So at this point, I would like to ask you, what do you think are the possible causes? You look into your material, identify the possible causes. Oh, I've already shown you. One of them is pulmonic stenosis. Remember, the pulmonic valve is the valve that controls the outflow of blood from the right ventricle through the right pulmonary artery, to the lungs. Yes. Okay. So it's the valve. So if the valve is stenosed, it means that the right muscles have to do much more work to be able to maintain the normal flow of blood. All right. So another possible cause is pulmonary hypertension. Now, you remember your article, the article I gave you, if there is a constriction of the blood vessels in the lungs, you have a state of pulmonary hypertension, and it's going to put a lot of strain on the right heart, and this is something that can also result in hypertrophy. And if it's not contained, if it is not corrected, eventually it will result in right-sided heart failure. And the next thing that can cause it is diarrheafilariasis. Remember the parasite Diarrheafilaria immitis, the adult worms lodges in the pulmonary artery. They lodge in the pulmonary artery, okay? And if they are very severe, they can also extend into the into the right ventricle, and their presence there will also result in right ventricular hypertrophy. Now, there's a next question I asked here. What are the possible extracardiac complications? I'm going to urge you to go and study it, look at it in your material. Okay, let's proceed. Now, this is another picture showing a myocardial hypertrophy, and unlike the one we first saw, this is now happening on the left, right? Now, what are the possible causes? I'm going to leave you to find out that from your materials, and also find out what are the extracardiac complications. These are basic things that you should know. It will help you in both your practicals and also in your oral exam. Now, let's look at some abnormalities, some congenital abnormalities. This is an ectopic heart. Of course, you know that ectopic heart simply means a heart that is not in its normal position, right? Now, if you look at this, you can see that the heart here, instead of being in the mediastinal region of the thoracic cavity, you can see it being located at the cervical region, just underneath the neck. Okay, the neck. Or you can also describe it as being presternal in position, because this is where the sternum started. So you can see the heart is more presternal also in the cervical region. Now, this is an ectopic heart, and usually the animals would not really survive long. Any animal that's giving birth with this kind of abnormality is just a matter of time before it packs up. Now, let's look at the second one. This is showing what we refer to as persistent ductus arteriosus. Now, this is the persistent ductus arteriosus. Of course, you know the word persistence means that it persisted. It's not supposed to be here. It's not supposed to be here after birth. Now, this is a shunt that is present in fetal life because the lungs have not yet been inflated. Remember, in fetal life, the animal is still within the womb. Okay, so the lungs have not been inflated, so there's no need for the blood to pass through the lungs to be oxygenated. The animal gets oxygen through the umbilical cord, right? Now, this is a shunt that makes it possible for blood to pass from the pulmonary artery into the aorta and now moves into circulation, right? But now in this condition, PDA, after life, this persists, because in normal conditions, after the animal has been given birth to, or the human being has been given birth to, this atrophies, it shrinks, it atrophies, right? This shunt atrophies, and of course stops the shunting of blood from the pulmonary artery into the aorta. But if it persists, blood will continue to be shunting, meaning that deoxygenated blood coming from the right heart to the pulmonary aorta, instead of most of them going, or rather continuing to the lungs to get oxygenated, some of those deoxygenated blood, or most of those deoxygenated blood, will pass through this shunt into the aorta, and you will have deoxygenated blood being circulated once again in the systemic circulation. Okay, and one of the clinical manifestations of this condition is cyanosis. This is what happens when you hear of a blue baby. You hear blue baby syndrome. The baby is bluish. It means that the baby is lacking oxygen. This could be one of the causes. Okay, this could be one of the causes, because a deoxygenated blood is bluish in color. Remember that, right? So if it passes into the systemic circulation, the baby or the newborn will be looking bluish. Now let's look at the next condition. This is persistent right aortic arch. Now, this is also one of the shunts that should actually remove at birth. But if it doesn't dissolve, okay, no, this is not really a shunt. I'm going to, so here the right aortic arch persists, and you can see it constricts the structures that passes through it. Now this is the esophagus as it passes. This is the rostral or cranial part of the animal, and this is towards the stomach. Now you can see how this structure here, because of its persistence, constricts the esophagus. Now this is the trachea and this is the aorta. Okay, don't mind the black and white picture. Now this is the heart and these are the lungs. All right, now you can see how it constricts it, and then you will have this bulging here. That's what's referred to as megaesophagus, and is something that is not actually compatible with life. As a matter of fact, after some time, the animal will have to die. Now, let's look at some conditions that can be seen maybe as a result of disease. And the first we're looking at here is this structure. Okay. Now, I know if I ask you to identify this organ, it's going to be a structure. Many of you may start cursing me. Now, look well, you see that this is the lungs. This is the caudal lobe of the lungs. This is the middle lobe. This is part of the cranial lobe. Now, this is the caudal lobe of the lung on the other side. Now, do you see this structure here, this large balloon structure here? This is a severe case of hydropericardium. Yes, hydropericardium. This is the accumulation of excess fluid in the pericardial cavity. Now you can see how big this is. Now the first thing it tells you is that the fluid accumulated over a long period of time. Okay, because if the fluid accumulated rapidly, it's going to cause heart failure, because it's going to affect the heart functionality. But if it accumulates over a long period of time, what actually happens is that it gives time for the fibrous structure of the pericardial sac to be enlarging, to be stretching, to be able to accommodate it. So that's what happens here. Okay, and this is one of the kind of lesions that you find in heart water disease. Heart water disease. I'm not the person that taught you guys this disease. I don't think I taught your class. But heart water disease, you find this in, as a matter of fact, that's why the disease got that name, heart water. Now, the next slide here shows myocardial hemorrhages and also serous atrophy of pericardial fat. Now, if you look at this is the surface of the heart. Remember, this is the apex. The base should be somewhere around here. This is the left heart, this is the right heart. You can see the coronary vessels running along where you have the interventricular septum. Now, if you look at the surface of the heart here, you can see that these red areas, these are areas of hemorrhage, and this is what you describe as ecchymotic hemorrhages. Of course, remember, you have ecchymotic hemorrhages, you have petechial hemorrhages, which are more pinpoint, you have suffusive hemorrhages, which are more widespread, and you also have the paintbrush hemorrhages. Okay, I'm sure you're already familiar with those terminologies. So this is what you find in diseases where there is blood poisoning, maybe bacterial septicemias or toxic or toxemias. Okay, yeah, these are the kind of hemorrhages you find. Maybe in snake bite envenomation, okay, or where you have poisoning, you also find this kind of hemorrhages. Now, here is serous atrophy of pericardial fat. If you look at the pericardial fat here, in a normal animal that is healthy, the fat should be normal in this pericardial, in this coronary groove. This is what is referred to as the coronary groove, okay? But if you look at the pericardial fat here, you can see that it has become gel-like. He has become gel-like. It's because he has undergone atrophy. And the kind of atrophy it underwent is what is referred to as serous atrophy. So it now looks as if there is oil, as if there is serous fluid inside and a transparent material. Okay. Now, what causes this? If the animal was sick for a really long time and is not eating, the animal suffered from anorexia or inappetence for a while before it died, you are going to see it as postmortem. And it's simply because the body had to mobilize fats here for energy production, which is something you refer to as gluconeogenesis. Okay, I hope that's clear. Now let's look at this one. This showing here hemopericardium. Now, of course, I know you still remember that hemopericardium simply means the presence of frank blood or clotted blood within the pericardial cavity. Okay? And of course, what are the possible causes? It could be as a result of rupture, maybe rupture of the intrapericardial aorta, or even rupture of the atrium, of the atrial walls. That's what will result in blood accumulation within the pericardial cavity. Now, the next picture here is showing epicardial mineralization. Now, if you look, you can see this whitish deposits on the epicardial surfaces of the heart, right? These are mineral deposits. And here on this side, you have a histology showing the mineral deposits, okay, in the epicardial layers of the heart. Now, this stain that was used for this histo here is the routine stain referred to as H&E, hematoxylin and eosin stain. Okay, down, that's the routine stain. Now, in H&E, calcium, okay, which is what actually happens here. The deposited mineral here usually is calcium, okay. You can also have urates being deposited, whether calcium or urates under H&E, they will appear as amorphous basophilic materials. These basophilic structures you are seeing here are calcium deposits within the tissues. Okay, yeah, and of course, I know you still remember the different kinds of calcification. Now, the next picture we are seeing here is what we refer to as the bread and butter appearance of the epicardium. Now, this is a severe case, of course, of suppurative pericarditis. Now, what you are seeing here is a mixture of fibrin and suppurative materials. And of course, you can see when the pericardium was opened up, it gave a bread and butter appearance. For those of you that were in class when I described this, I'm sure that you still have a mental picture of the analogy I used using bread and the butter. Okay, and this is what you see in the case of traumatic reticuloperitonitis, also known as Hardware's disease. And I urge you to go and look at the pathogenesis once again, just as a reminder. Now, here we have valvular endocardiosis. Now, look at this picture. You will see this, of course, here is the atrioventricular. Now, this is atrium. These are the ventricles. This is a heart that has been cut open. Okay, these are the ventricular muscles here. This is the heart chamber. So this is the atrium. This is the ventricular chamber. So this valve here is the atrioventricular valve. Okay. Now, of course, I'm sure you remember that the valve is made up of the cusps, okay, which are fibrous materials. Then, of course, the chorda tendineae, which attaches to the papillary muscles. Now, this chorda tendineae, this papillary muscle. Now, this white area you're seeing here are the valve, the cusps. Now, these three structures makes up the valves, right? The atrioventricular valves. Now, what pathology are you seeing here? You can see that on this valve, or on the cusp of the valve, you can see that there are nodular thickenings. These nodular materials, it's much more clearer here. You can see the nodules on the cusps. This is the chorda tendineae, and this, of course, is the papillary muscle. Now, if you look here, you can see these nodular thickenings here. These are the lesions that you find in the case of valvular endocardiasis. Okay, now is a myxomatous degeneration of the the cusp materials. Okay, it gives that thickening, and it's quite common in dogs, and for some reason it's mostly observed on the left atrioventricular valve. Now, what does it cause? It causes valvular insufficiency, because valves that have this degenerative change cannot be able to function properly. So you're going to be having reflux of blood when the right ventricle or the left ventricle contracts, and is supposed to send out blood through the aorta into the systemic circulation. Some of the blood will now also move back up. That's what is called regurgitation. It moves back up into the atrium where it came from. Why? Because these lesions will not allow the valves to close properly in a so that blood cannot regurgitate back. Okay, yeah, so that's what happens. Now, the next lesion I'm showing you here is the cousin the cousin of valvular endocardiosis, which is valvular endocarditis. Now, when you hear cardiosis, osis is talking, it suggests, or it's conveying to you that you are dealing with a degenerative change. But when you hear carditis, itis, it's telling you that you are dealing with an inflammatory condition. Now, in this is similar to what we discussed for endocardiosis in terms of location of the lesion, but the lesion now differs here because what you now have are rough granular masses, and they are also very friable. So they are rough, they are granular, they are friable masses attached to the valves. Okay, now these are masses of mixture of bacterial colonies, blood clots, fibrin. Okay, and because they are very, very friable, they can break off. So some part of them can break off, and if it gets broken off, it flows in the blood as an embolus, and it can get lodged in any organ, and any place that it gets lodged in and blocks further movement of blood into the tissue, you are going to have pathology there. For instance, if it breaks off and get lodged in the tiny vessels in the kidneys, you are going to have renal infarcts happening as a result of the embolus. Okay, so this is what you find in valvular endocarditis. Now, this next picture here is showing some random conditions which I think we've talked about, and mineralization. The first one which I showed you was epicardia, because it was on the epicardium. Now, this is endocardial mineralization. You also have deposition of calcium minerals on the endocardium, right? And of course, I urge you to go and think about possible causes. Of course, hypervitaminosis D should be at the top of your reasoning now. And of course, now this is the lymphocyst. You can see it developing on the valve. This is papillary muscle. This is the chorda tendineae, and then these are the cusps of the atrioventricular valves. Now you can see here that a cyst is lymphocyst because it's lymph fluid that is here, that is inside the cyst. Unlike this one, you have hemocysts, is blood that is inside the cyst in this condition. Okay, now these are incidental findings, and usually they don't result in much pathology. Now what I'm going to be showing you here is what we refer to as heart failure cells, and I hope you remember the condition where you find heart failure cells. Okay, so what are these heart failure cells? They are basically pulmonary alveolar macrophages. Remember that there are, in a normal lung, you have macrophages that move around freely. They are like so a part of the immune system of the lungs. Okay, so they move around, and if they see any invading agent, they engulf it and destroy it. Okay, now heart failure cells are simply macrophages, pulmonary macrophages that have engulfed and destroyed lots of red blood cells, and you now have the byproduct of hemoglobin, which is now heme, present in the cytoplasm of these pulmonary alveolar macrophages. Now these under H&E will stain golden yellow. Okay, yes, and this is a condition you find mostly in cases of left-sided heart failure. Okay, and I urge you to go and read about it. Okay, yeah, because you're going to have pulmonary edema in left-sided heart failure because of the stasis of blood in the lungs. You're going to have a lot of diapedesis of red blood cells from the pulmonary circulation into the alveoli, and when this happens, the pulmonary macrophages engulfs them, destroys them, and you now have the formation of heme within the cytoplasm of these cells. Now this is nutmeg liver. You can see the name, okay, because when you look at the cut surface, it looks like the nutmeg. For those of you that bake chin chin, you bake cake, and you use nutmeg, this you agree with me that this is what nutmeg looks like, and this is a condition you find in right-sided heart failure. Okay, and why is it? And why do you see it in right-sided heart failure? Because in right-sided heart failure, you have pooling of blood in the liver, in the spleen. Okay, and because you have pooling of blood in the liver and the spleen, now the hepatocytes that are immediately surrounding the central veins, they undergo degeneration. Okay, they undergo ballooning degeneration, also referred to as vacuolar degeneration, right? And that's what gives this variegation, these differences in color that you see at the cut surface of the liver. Now the next pathology I want to show you here is vascular thrombosis. You can see the abdominal aorta as it runs down and then bifurcates. At this point, you can see the deposition of not deposition really, but the presence of thrombus within this abdominal aorta towards the inguinal region. All right. Now, how do you differentiate postmortem thrombus from antemortem thrombus? I'll leave that to you to decipher, but I'll just give you a clue. In one, there is adherence. In the other one, there is no adherence to the wall, the luminal wall of the blood vessel that is affected. Now, this here is showing atherosclerosis. Okay. Now, grossly, you can see what it looks like. These are hearts, and these are the hearts, the coronary vessels. You can see that they are now thickened and looking like pipe. Okay, you describe it as pipe-like lesions. all right, of the blood vessels of the heart. Now, this is a cross section of one of these, and this is the lumen. And you can see within the wall here, you can see these structures. These are the ghosts, referred to as them as the foam cells. Okay, not ghost cells. They are foam. They refer to as foam cells. Foam cells, and these are macrophages, and of course, the muscle cells that are filled with lipid. They are filled with lipid. Okay, that is what gives the cytoplasm this foamy appearance. Now, what's the consequence of that lesion? When you have this deposition of foam cells within the walls, as it's growing, is occluding the lumen. And at some point, when it forms full occlusion, there will be cessation of blood flow. And eventually, what do you have happening? The parts of the muscle that those vessels, the affected vessels, supply, will begin to undergo infarction, right? So that's what happens in cases where you have myocardial infarction. Now, this is a real-life picture of a case of myocardial infarction. The arrow is pointing at those areas. You can see they are dark red. These are areas of myocardial infarctions. And what happened here is that there's impedance of blood flow to these areas, resulting in their necrosis. Now, the other lesion that I want to show you is arterial media hypertrophy. So you can see here that the tunica media becomes hypertrophied. And of course, as it's hypertrophying, what happens to the lumen? The lumen begins to thin out the more. Okay, so it happens mostly in the arteries and is a degenerative change. You can find it in the lungs. You can find it in any case where parasites can, migrate through the blood vessels. Now, the next lesion I want to show you here is my medial calcification. Medial calcification. Now, this is a schematic diagram showing you actually what happens. Of course, medial, meaning the tunica media. And what do you have in the medial? Muscles, smooth muscles. Remember, the blood vessel is made up of tunica intima, tunica media, and then the adventitia. Okay, so when you have deposition of calcium within the muscles, that's what we refer to as medial calcification. And you can find that in cases of vitamin D toxicosis, or in a situation where the animal consumes calcinogenic plants. Now, the next lesion here, we've mentioned it before. This is diarrhofilariasis. You can see lots of the adult worms within the right ventricle, and you can also see them. This is the pulmonary artery that has been cut open. You can see they are there in the pulmonary artery, and in severe cases, they can also be found within the lungs, right? Severe cases. Now, of course, these worms can cause heart failure, right? Yeah, it can cause heart failure. Now, the next thing I want to show you here, because I want to quickly end this video so that we move on to spend more than an hour watching this. Now, this is what you find in myocardial lymphosarcoma. It's one of the cancer, one of the tumor conditions that affects the heart. And of course, remember the name, lymphosarcoma. So it is a metastatized lesion. It's metastasized to the heart. It's not a primary tumor of the heart. It's a secondary tumor of the heart. Now, looking at it at the gross here, you can you see these changes in color, these grayish areas? These are masses of infiltrating tumor cells. Now, this is a cross section. You can see that he has damaged a lot. He has even caused thickening of the interventricular septum, and also some thickening of the right ventricular muscle as well. Now, this is what you see at the histological stage. Now, this is what this pinkish materials here is what is left of the heart muscles. You can see here you have a lot. These are massive, infiltrating tumor cells. You can see how they crowd out and they begin to compress the muscles and resulting in the necrosis of the muscle fibers. Okay, so this is what you find at histological level of myocardial lymphosarcoma. Then, of course, when you look at these cells, you are going to see the different markers or indices associated with neoplasia. Things like high nuclear to cytoplasmic ratio. You also talk about things like mitotic figures and the rest of them. Now I want to show you another thing. This is a case of eosinophilic myocarditis. Now you remember when I was teaching you myocarditis, I told you that myocarditis can also be classified based on the predominant cell type, right? Now in this case, this is a case of eosinophilic myocarditis. Now, if you look at the predominant cells, inflammatory cells here, you can see they are eosinophils. Eosinophils have pinky cytoplasm. Now, I put this picture here to just remind you of what they appear as in a blood smear. You can see they have pinkish granules. That's why here you can see them. These are eosinophils. They all have pinkish cytoplasm, and this is what you find in cases of parasitic myocarditis. Now there's this one here is showing you what you find in lymphocytic myocarditis. Sorry, I have to go back. Lymphocytic myocarditis. Now this here is a blood smear showing you again what the lymphocytes look like. Okay, you can see they are much more smaller than the previous cell. The eosinophils that I showed you here, look at the eosinophil, look at how big they are, how large they are compared to the erythrocytes. Okay, but if you look at the lymphocytes here, you can see they are almost the same size with the erythrocytes. Now these are the lymphocytes. You can just see just one roundish bluish structure because the cytoplasm is thin. So this is what you find in lymphocytic myocarditis. You have a predominance of lymphocytes, and it's mostly associated with viral myocarditis. Can you give me one disease of POPs, one viral disease of POPs that have myocarditis? Can you think of one? Yeah, keep it to yourself. I'm sure you're correct. Now, this next one here is showing you suppurative myocarditis. And in suppurative myocarditis, the predominant cell types here are neutrophils. Okay? So, you can see these are neutrophils. They are neutrophils. Okay? They are the predominant cell types, and that's what you find in a case of suppurative myocarditis. Now here you have a myocardial neoplasm. Okay, I can't really tell you the type of neoplasm you may be looking at here based on their appearance. Okay, but you can see the structure, you can see the large mass. Okay, and it seems as if it lobulated. It has different lobules. Okay. And this large mass is located on the wall, involving mostly the wall of this is the left ventricle, so this left atrium. Now this next picture here I want to show you is forget about the kidney. The kidney of course has its own pathology, but the focus here is this lesion here. See another one here. We talked about aneurysm. We talked about the saccular aneurysm, aneurysm. This is what it looks like. Okay, and of course, I hope you still remember what aneurysm means in general. Okay, now this is showing just the tetralogy of Fallot. And what do you find in this condition? This is actually supposed to come when we were talking about congenital deformities, but I guess I may have I've made a mistake in the preparation, but it's okay. So, what did we say involved in tetralogy of Fallot? Number one is pulmonary stenosis. So you can see the stenosis of the pulmonic valve. That's the first thing. Then secondly, you have hypertrophy of the right ventricle. So because of this stenosis, the right ventricular muscle becomes hypertrophied. Then the third thing that is involved in this tetralogy, I hope you understand that tetralogy means four, right? So the third thing you see is that there is ventricular septal defect. In VSD, that's ventricular septal defect, there is failure of the interventricular septum to fully close. So it leaves an opening, a connection between the right ventricle and the left ventricle. So that's one thing that you see. And the last thing is that you have an overriding aorta. Okay? So because of the ventricular septal defect, the aorta overrides and connects to the right ventricle instead of just flowing out from the left ventricle. So that's what you find in a case of tetralogy of Fallot. And I hope this now clarifies what tetralogy of Fallot means to many of you, because I know sometimes when we talk about this in theory, it can become confusing. Now, this is a live picture showing the ventricular septal defect. You can see the hole here. Okay, remember this is a ventricle. You can see the valve. Now, there is this hole. There's this hole, this connection. Look at it here again, showing the connection between the right and the left ventricle. Ideally, it should close within the first few weeks of life. But in some cases, it persists. And I'm sure many of you may have heard of stories where they say, hey, there's a baby that was born with a hole in the heart, and this, that is what it's talking about, a ventricular septal defect. Now, some animals, for instance, Alsatians, can live with it. It may not affect the Alsatian very obviously, but when the animal is subjected to severe exercise, the symptoms will start showing up. Okay, but usually they live with it. Some people can live up to 6 years, 7 years with a hole in their heart, but it's important that it's corrected surgically as early as possible. So this is the last slide of what I'm going to be showing you, and I wish you good luck in your exams. So have a good night if it's night where you are. Bye.